one last thing before we move on from this topic of hormone therapy and target therapies are the PI3 kinase inhibitors. And as we all know, PI3 kinase mutations are the most common mutation in breast cancer. And clearly, obviously, we want to try something because it's the most common mutation. But to me, it's just been a little bit on the disappointing side so far. Any comments? I mean, let me start with Jose and then Debu.
Yeah. Well, my comment would be keep the faith. So we had the first series of inhibitors. Buparlisib was one of them. Remember, buparlisib, the study was positive. It had a difference, but the toxicity was very significant, so it was not doable. Patients only stayed on for less than 2 months, and yet you saw a very different. The outcome was different. Now we have 2 alpha-specific inhibitors that are far less toxic. You have alpelisib and then you have taselisib. You have 2 phase 3 clinical trials that are enrolling incredibly well. You have the Sandpiper on one side, and then you have the Solar on the other. And these studies are going to be out by the beginning of next year, end of this year. Based on the single agent data that we have, we just published a paper in Cancer Discovery with the phase 1 data, 36% response rate in PI3 kinase mutant.
Across tumor types?
Yes.
Across all tumor types?
No, this is breast.
Just in breast.
Yes. So they're active. And it's going to be an issue on how tolerable they are. But these alpha inhibitors, so I would say, if I had to say, I am very optimistic.
Okay.
Yeah, I agree. I think that we have to know who to treat. I mean, even with the Bell study, which is a pan-PI3 kinase inhibitor, there was clearly a signal that those with activating PIK3CA mutations responded. So I think it's a matter of selecting the patients, and clearly there will be a. And the other thing that we have to understand as time goes on, we have to really pay attention to the correlative studies. You all had a very nice paper come out in Science looking at epigenetic modifications and as a clue to at least one mechanism of resistance. So I think that these drugs will probably be used in combinations as we start to understand the mechanisms of resistance and develop rational combinations.
But it's going to be tough. I mean, all of these people, at least in the PI3 kinase trials to date, are CDK4 naive, right? And that's going to be tough.
I think if I had to say, it's probably going to be neutral, because one of the things that is interesting is that the CDK4/6 inhibitors, they're working independently of PI3 kinase mutation status.
Yes, they are. Good point.
And
Very
that
good
could be,
point.
and that could be an indirect evidence that they are working through non-overlapping mechanisms of actions. I would hope.
Good point.
The other point to make about Solar 1 and Sandpiper is that those studies are powered to answer the question whether these drugs are better in the mutant population or in the whole population.
Right. And that gives us yet another reason to do circulating tumor DNA on people.
In fact, I know that Solar 1 is using plasma tumor DNA in all patients. So this could be, perhaps, as suggested by Bell 2, the first targeted therapy that may be associated with a plasma tumor indication.
And as long as you're doing, you're doing it for one, you might as well do it for a couple,
Absolutely.
right? You're already doing PI3 kinase, do ESR1, maybe HER2, tyrosine kinase domain, and suddenly we'll be like the lung guys. We'll actually have, genomics that we can use.
Well, I think also, like the Fergie, which was a negative trial, but I think much what Carlos was saying, they were measuring the PI3 in the primary tumor. So now that we're able to really measure real time with circulating tumor DNA, I think we may really see some differences and see that signal now emerge a lot stronger.
But the other lesson from these trials is that we have to really strive to use target-specific inhibitors, PI3 kinase alpha inhibitors. Think about it. I mean, I think there's going to be a time where we'll have a PI3 kinase mutant-specific inhibitor. Right. There's an inhibitor from Genentech that seems to look that way. Really? Right. So think about that. The inhibitor that will not give you rash or hyperglycemia begs the question: what would you use as your biomarker for in the phase 1? Right. But we'll get there one day, I think.